So good evening, one and all. And at the outset, I would like to thank all the organizers of Lung Update. And I'll be presenting. This is not as mature data as Dr. Kripa has presented, but this is the before the phase 3 trial, what happens and how the pembrolizumab came into this area of neoadjuvant. This is what it will be about. So I'll be presenting the neoadjuvant pembrolizumab for early stage non-small cell lung cancer. So the background, as already discussed in detail, the checkpoint inhibitors actually prolong the benefit for some advanced NSCLC patients. We know it from the metastatic setting very well. And the 5-year survival rate has improved in the non-cell NSCLC non-small cell lung cancer patients, but it is still unsatisfying. We are not satisfied by the number which is not touching the third digit, and it is still 60% in stage 2A, and it drops drastically once the stage increases from stage 2A to stage 3A to almost half, that is 36%. We know that adjuvant and neoadjuvant chemotherapy has shown improvement in the 5-year overall survival, but that has been very small, 5 to 8%. And a neoadjuvant checkpoint inhibitor treatment might actually be more effective than adjuvant treatment. So, and also we can see the effect of this checkpoint inhibitor in vivo. So, neoadjuvant checkpoint inhibitor actually is being explored, as already elucidated in the previous talk, for early NSCLC, and usually it is in the combination with chemotherapy. So as already mentioned, nivolumab has already come up with a good data, especially for one of its primary endpoint, that is MPR, and EFS data is yet to come. Other agents which are already in line are atezolizumab, pembrolizumab, and durvalumab. So we actually, in few years of time, maybe at the when the next meeting happens after around 3 or 5 years, probably we'll have multiple choice from where and which immunotherapy to choose from, with combination of standard chemotherapy, and probably will be spoiled for choice at that time. So the optimal neoadjuvant at this point of time, which is a perfect checkpoint inhibitor, we still don't know. So I'll be talking about the pembrolizumab in this setting, and this is MK3475223. It is basically a phase 1 study design, and we know how the phase 1 studies are designed. And the primary endpoints again was a safety, and what would be a recommended dose for the phase 2 dose schedule. And of course, what was the pathological response? They also wanted to see that whether this is improving the path CRs or not, or MPRs or not. The secondary endpoints were recurrence-free survival and overall survival. There was an exploratory endpoint exploration, basically to explore the mechanism of response and resistance to the checkpoint inhibitor, that is pembrolizumab, in this setting. So the cohort 1 started with 3 patients. With the way it starts in chemotherapy also in all the phase 1 study. So they gave pembrolizumab at the point of diagnosis. And after 3 weeks, the patient underwent surgery. This was the first cohort, and they saw that there was no DLT, that is any dose-related toxicities. And then the second cohort was planned, which was again giving pembrolizumab at the beginning. And after 3 weeks of that, the second dose of pembrolizumab was given. And minimum gap of 2 weeks was there, after which the surgery was done. When this was again having no DLTs, it was gone to cohort 3. This time, the difference between the cohort 2 and 3 was there was an extra 1 week difference after the second cycle of pembrolizumab, and then the surgery was done. So the pembro doses which was given in cohort 1 was 1, and cohort 2 and 3 was 2. The expansion cohort was planned for 10. And this is how the study was conducted. It initiated in January 2017. The expansion cohort target was 29 for the maximum, and which they were expecting to finish by January 2020. in November 2020. Due to slowed recruitment, we know from last 2 years it is becoming very difficult because of COVID-19 pandemic to recruit patients onto the trial. So this 26 patients which were treated, out of that 3 patients went into the cohort 1, which received only 1 dose of pembrolizumab. Cohort 2 and 3 combined had 23 patients which received first dose, followed by the second dose, which was in 21 patients. 2 patients, SAE happened and hence the surgery was cancelled. After the second dose, 1 patient refused surgery. So out of 23, 3 patients were excluded and 20 patients underwent the surgery which was planned. So what was the result of this phase 1 study? And we saw that the authors saw that there was no dose schedule limiting toxicity which occurred in this dose schedule escalation cohort. 21 patients who received 2 cycles of neoadjuvant pembrolizumab. There were 21 patients out of total 26, and 7 patients actually achieved the major pathological response. And there were 3 patients more which had an excellent response, almost complete, the pathological complete response. So out of 23, 10 had a very good outcome, histological point of view. And this was seen mainly in patients who had received 2 cycles of pembrolizumab. These all patients who followed by surgery, usually for more than 5, because cohort 2 was after the 5 weeks of treatment initiation, and cohort 3 was after 6 weeks of initiation. What they saw was there was no correlation between the PD-L1 pre-treatment and the pathological response achieved by the pembrolizumab. Also, the size of tumor and the nodal status was not having any apparent correlation with the MPR. All the MPR cases actually had relatively longer interval from the first treatment till surgery. So longer the interval, the more chances of achieving PathCR. This was the detail of the patient characteristic according to MPR status, whether yes or no. And we can compare the yes and no and see whether it was significant or not. So we can see different parameters on the right side of the screen, whether it was age or male patients, how many percentage of male patients. Both did not lead to any significant difference. The median age was somewhere around 71 and 64. Percentage was 86% and 38% in no. Whether smoking status, yes, past or never smoker, did not make much of changes. Pathologically, we know that it is adenosquamous or adenosquamous, and all of them did not make any significant difference. Even the tumor size and the nodal status did not make an impact on MPR. And the only thing which was significantly found and showing some difference, longer the interval, more chances of achieving MPRs and PathCRs. So after seeing the efficacy and achieving the PathCR, patient underwent surgery. We also should not forget how the patient tolerated the therapy. So the toxicity comes into the picture, and we see that almost 80% had some kind of toxicity, some adverse event, but the major adverse events like grade 3 and 4 were seen in 1/3 of the patients, that is 35%. There was no death related to the treatment. The TRAE of any grade was somewhere around 60%, but the severe grade 3 and 4 were hardly 10% and less than 10%. TRAE leading to the treatment delay was less than 10% again, and discontinuation rate due to the treatment was again less than 10%. Leading to any adverse event leading to the surgery deferral was again less than 10%, and there was no hardly 15% of the patients. So this they saw that there was no DLT in the escalation cohort, as we have already mentioned. The MPR which was observed in patient with the time interval from initiation of the treatment to the surgery was 5 or more than 5 weeks. The recommended dose schedule, the way they wanted to do was what they found was pembrolizumab followed by 3 weeks gap, second dose of pembrolizumab, minimum gap of 2 weeks, and then for surgery. The exploratory endpoint among the patient treated by this dose schedule, we can see that the MPR was achieved in almost 44%. That was 7 out of the 16 patients. And the PATH CR was achieved by 19% of the patient, 3 out of 16 patients. So we can see almost more than 60% of the patient had good response. Coming to the secondary endpoint, which was the relapse-free survival, as we can see from this graph, Kaplan-Meier graph, the 1-year RFS was 100%, 2-year RFS was somewhere close to 92%. The same thing in overall survival. At the end of 1 year, it was 100%, and at the end of 2 years, it was 93 months. The 2 deaths which actually occurred, one was because of the disease progression, and one was unrelated to the disease, that was related to the sepsis. So, what is the take-home message from this phase 1 study? The neoadjuvant pembrolizumab is safe. Less than 10% patients are having grade 3 or 4 TRAE. With actually no apparent relation to the treatment surgery interval. The outcome in the entire cohort, if we see that it was 26 patients to begin with, it was still a good 40%. That amounts to almost 40%. The longer the interval from the treatment initiation to the surgery, it was associated with higher rates of MPRs. And 2 doses of neoadjuvant pembrolizumab at 3 weeks interval followed by surgery at 2 weeks or later was the phase 2 dose schedule, which was understood after this phase 1 trial. If we go by the exploratory look at the patients who were treated by the schedule, which was RP2DS, then it escalated to more than 60%, 63% patient having a pathological response, MPRs of 44 and PATH CRs of 19%. On the similar line, they have come out with the keynote 671, but here they have used not only pembrolizumab but actually the combination of CIT, that is chemoimmunotherapy. The way nivolumab has showed good result in Checkmate 816, I am expecting that probably pembrolizumab also will show good results. And there are other trial like Agent, which is going for durvalumab, IM power 030 for atezolizumab. So we are actually having a lot of immunotherapy, chemotherapy combination, and soon we'll see an improvement in EFS and overall survival also in our cancer patients. So this is our team from Sangam. Thanks a lot for patient listening.